Hello and welcome to another MDC question style walkthrough. I'm Dr. Iken Skuzi and I'll be taking you through today's session. Today's question says, a patient with no known chronic illness presents with abdominal pain that started about 8 hours prior to presentation. So abdominal pain 8 hours prior to presentation. The pain is associated with vomiting and fever. About a week ago, the patient experienced malaria-like symptoms and took over-the-counter anti-malaria medications. Okay, so malaria-like symptoms and took over-the-counter medications. An erect chest X-ray of the patient is shown below. So this is the X-ray of the patient, and the question says, what is the most likely diagnosis? A. Enteric fever. B. Appendicitis. C. Bowel obstruction. D. Pyelonephritis, and E. Bowel perforation. So let's go through the stem of the question once again and pick up the salient points. Try to read the X-ray itself and see how we can put the findings together to make a final diagnosis. So we've already kind of outlined some of the key things that have been mentioned in the question. We've been told that the patient has abdominal pain and it started about 8 hours ago. This shows that this is some form of an acute abdomen, so it's a sudden onset abdominal pain, and that he has fever and he's vomiting. And one important thing we've also been told is that about a week ago, the patient had some symptoms that resemble that of malaria, and the patient took anti-malaria medications, over-the-counter anti-malaria medications. And this is a very classic history that you see when you start practicing, where you see patients coming in. Sometimes they don't even report these malaria-like symptoms, but when you do probe, you find out that the patient was unwell a couple of days ago, prior to this abdominal pain that brought them in. And most of the times they will say, oh, they thought it was malaria, and so they took anti-malaria medications. And one thing that happens very common in our setting is that patients take malaria medications without testing for malaria, and that's what happens. Most of the time it's not malaria, but then they assume it's malaria and they go and buy malaria medications. They take it, it looks like it's getting better, but it doesn't get better, and then it worsens a few days later. And so this is like a typical history that you tend to get for patients in our setting here coming in with symptoms days later after it's worsened. So we've kind of picked up the salient points here. The question wants us to make the most likely diagnosis, and that is what you typically see in MCQ questions. They will tell you the most likely diagnosis. They want the most likely diagnosis, and not just possible diagnosis or possible differential diagnosis. Because when we look at this, the stem of the question and the information we've gathered so far, all these differential diagnoses can possibly present with all these symptoms. Pyelonephritis can present with a fever, it can present with vomiting, and the patient might have the general malaise symptoms prior to coming in with the abdominal pain, and bowel obstruction and bowel perforation, appendicitis, enteric fever. All of these differential diagnoses can possibly present with these similar symptoms. But we've been given an image to try and read and then help us narrow down our differential diagnosis to the most likely diagnosis. So let's move over to the X-ray to see what we can find. This is a chest X-ray. It's an erect chest X-ray, we've been told in a question, and they want us to pick up the key findings. When you look at the lung fields here, when you look at the chest itself is fine. Airways are fine. There's no evidence of tracheal deviation. The lung fields are fine. They are clear. The heart size itself is normal. There's generally the thoracic cavity, lung fields, everything in the chest region seems normal. But when you look down, when you continue to read the film and you go down towards the abdomen, what you find is that you find these radiopaque structures here. These are very thin lines here that you typically don't see on an X-ray, and these are the diaphragm. So typically the diaphragm is adhered to the liver here, and it's usually on the right side, so it appears radiopaque, and you don't tend to see the liver separated or the diaphragm separated from the liver as we are seeing here. So these white lines that I've outlined here are the shapes of the diaphragm. And then on the right side, you now have the liver. So this is the liver here on the right side. So let me use a different color. So this is the liver there on the right side, and on the left side you have the gastric bubble over there. And now in between these structures and the diaphragm, you now have this radiolucency. So, and this is gas. Okay, so when you look at it on the left side, the space in between the liver and the diaphragm is this radiolucent area, or this dark areas, and it's because there's gas in there, and that is gas. That is the evidence that there's a presence of gas under the diaphragm. And this typically you see when there's free gas in the abdomen. When there's free gas in the abdomen, because air or because gas is of low density, when you assume an erect position, what happens is that the gas now rises to the roof of the abdomen, and the roof of the abdomen is formed by the diaphragm. And so because the air is trying to push its way up, it pushes the diaphragm of these structures, and so you now have this radiolucency below the diaphragm, because the diaphragm is trapping it below it, and it's trying to push its way up. And so you have this radiolucency under the diaphragm, and this is typically described as the subdiaphragmatic gas or free air under the diaphragm. And it's a typical indication that there's free air in the peritoneum. So there's pneumoperitoneum. And the differential diagnosis for pneumoperitoneum are numerous, but we'll stick with the common ones in our environment. And so when you now look at this patient history and the clinical features the patient presented with and the X-ray findings, we can now start to narrow down a possible most likely diagnosis from the 5 options that we've been given. We know that free air under the diaphragm or gas under the diaphragm means that there's free air in the abdomen. So it has to be from a condition that can cause or that can lead to free air in the peritoneum. And one of that is a perforation of a bowel. Now, the perforation of a bowel could arise from appendicitis. It can arise from typhoid ileal perforation. It can arise from bowel obstruction. But all of this, for them to subsequently lead to free air in the peritoneum or pneumoperitoneum, there has to be a perforation. So at the end of the day, you realize that all these options are correct, but the most likely diagnosis here is the bowel perforation. So you see how they've put in distractors there, and they are looking for the most likely diagnosis. If it is in an OSCE station and you are speaking and you are chatting with the consultant and you are giving answers, if they give you this X-ray and this history and you mention enteric fever, if you are supposed to earn 5 marks in that station, you might just get 1 or 1.5, because enteric fever is not entirely wrong. This patient actually did have enteric fever, and that is important because of the history of the patient and the fact that this patient had this malaria-like symptoms. So that's a typical presentation of enteric fever or typhoid fever. And so they will have that typical history. But that is the situation doesn't end there, okay? It didn't just end with the enteritis. It went ahead to now develop a complication, and that is what brought in the patient, and that is a perforation. So if you mention that the patient has enteric fever, you are not entirely wrong, but you won't earn all the mark. Differential diagnosis of appendicitis, bowel obstruction. Bowel obstruction may be a little bit lower down the line, and pyelonephritis is a little bit lower down the line, but all of them are possible differential diagnosis. And enteric fever being the diagnosis, the initial diagnosis, and now subsequently developing a complication of bowel perforation. So in this case, the most likely diagnosis is the bowel perforation, and this patient bowel perforation is a typhoid ileal perforation, and so that's the diagnosis that you are going to make in this patient. So in the MCQ, the correct answer you choose is bowel perforation. It's good to always spend some time when you are answering the question, because MCQ questions are framed in such a way as to to distract you. They always put in the distractors. So out of 5 options, if you're able to rule out 2 of them, you are left with 3. And you try to spend some time to try and make, even if you are not very sure, you want to make the an educated guess. If you start out with 5 and you rule out 3, you are left with 2. you have a very high chance, even if you are guessing out of that at that stage. It's now a more educated guess, because you have a 50-50 chance of getting it right out of the two. But always look for these key phrases or keywords in the in the questions. Most likely diagnosis, things like that. They are looking for like specifics. Okay, and so once somebody could just read this question once and say, "Oh, enteric fever." Yeah, I mean that's not wrong, but that's not what the question is looking for. The question is saying the most likely diagnosis, and so you have to add everything together and make and try to make a more comprehensive conclusion out of that. Right. This is the chest x-ray. Again, this was the chest x-ray of the patient that we just discussed, and we are seeing the green overlay here is showing us the evidence of the free gas or the subdiaphragmatic gas, which is what is being described here. So typically what you do is that when you are suspecting that there's pneumoperitoneum from a perforated hollow viscous, we'll talk about the differential diagnosis of pneumoperitoneum. But pneumoperitoneum of whatever origin, you want to do a chest x-ray. So typically what you do is an erect chest x-ray, because that will show you the face, that will show you parts of the diaphragm where you have the interest is, because that's where the gas will be trapped, and not an abdominal x-ray. Abdominal x-ray typically will not show you this upper part, but sometimes if you do if you request if you put it in your request form, they can extend it to show you the outline of the diaphragm. But typically a chest x-ray will show you that right away. Right, and what you are looking for is a subdiaphragmatic free gas. Now, or the gas under the diaphragm, which is what is commonly described. Aside the fact that air under the diaphragm is from free gas in the peritoneum or pneumoperitoneum, sometimes there is appearance that looks like air under the diaphragm, but it's not really air under the diaphragm. So some of the differential diagnosis for such is called the Chilaiditi sign. Now in Chilaiditi sign, what is happening is that there's a bowel, it's just a bowel that has gas, and that is kind of entrapped between the diaphragm and the liver. Sometimes it's not even entrapped, it's just the position of that bowel and during the time of the x-ray, and so it looks like there's gas under the diaphragm. So for instance, take somebody who has a bowel obstruction from a volvulus, a sigmoid volvulus. So typically a sigmoid volvulus, the apex of the dilated bowel will be pointing towards the right quadrant, like that. So you have it dilated. So you have this dilated loop of bowel towards the right upper quadrant. And so when you do an x-ray and you don't look at it very well, it might look as though there's air under the diaphragm, but all that you are seeing is just a dilated loop of bowel that has gas in it, and it's not really perforated. If it is a cecal volvulus, for instance, the apex of that is always towards the left upper quadrant, and so in that case, you see that the lip of bowel, dilated loop of bowel, is somewhere trapped here, and then it will look as though there's air under the diaphragm. So that's one differential diagnosis that you always have to consider when you see air under the diaphragm. Another one is subdiaphragmatic abscesses. So when there's abscess collection, a gas containing abscess collection under the diaphragm, and you take an x-ray, that will also look radiolucent, and that will also appear as though there's gas under the diaphragm. Omental fat is radiolucent. So on an x-ray, if you have the omentum trapped between the diaphragm and the liver, or the diaphragm and the stomach, when you have that and you do an x-ray, it will also appear radiolucent, and that will also give the impression that there's gas under the diaphragm, when in actual fact there isn't gas. And the other is an enlarged gastric bubble, that will typically, you see that on the right side. And in this patient, actually, when you look very carefully, you realize that the gastric bubble is a little bit larger than usual, and you see that is quite very huge over here. And this is probably because this patient has probably started to develop some form of ileus, and there's already dilatation of bowels and things like that. But in a patient who does not have air under the diaphragm, sometimes they may have a lot of gas in their stomach, and then the gastric bubble will appear very large and huge, and it appears as though there's air under the diaphragm. So these are some of the things that you should consider when you are when you see air under the diaphragm, try to rule out other possible things that might look as though, there's free air in the stomach or in the peritoneum. Sorry. Right. So aside, the chest X-ray that we've just described, sometimes you can also request for an abdominal X-ray for patient that you suspect may have pneumoperitoneum, either from a perforated hollow viscous. And sometimes the X-ray that you do in the abdomen, you can do a lateral decubitus X-ray, where the patient is made to lie on their side, and when they lie on their side, part of that, the upper part of the stomach of the abdomen, in that case, would serve as the diaphragm that we've just described. So they are lying on their side, and this is assuming a dependent position. The gas will begin to rise towards the upper part of the lateral abdomen, and so you see that the gas will be trapped somewhere up here. So this is a lateral decubitus position. But sometimes, you do an X-ray, the patient is not very stable, especially in neonates, for instance, or an adult who is not very stable to even take an erect X-ray or to take the lateral decubitus position. You just do a supine X-ray, and if there's free air in the peritoneum, sometimes you see what is described as a Wrigley sign, also known as a double wall sign. Now, when you look at this X-ray, you see that you've seen these radio opaque rings or structures. These are the walls of the bowel. That's the wall of the bowel. Typically, you don't see the full outline of the bowel. What you typically see is there's the inner wall, the inner layer of the bowel, and this is because there's air in the bowel. So the lumen of the bowel has air. And so, because air is radiolucent, when you do the X-ray, there's radiolucency in the inner part of the bowel, but the other side is not radiolucent. So you can't really see the full wall of the bowel at the other side, but you can only see it in the inner side. But when you now have free air in the peritoneum, so you now have, this is the intestines, for instance, there's air in the inside of the intestines, and there's air in the outside, which is the peritoneum itself. So you have radiolucent outside here, radiolucency inside here. So there's darkness here, and in between those two darkness, you now have the wall itself, which is radiopaque. So now you see the full wall of the bowel, and that is called a double wall sign, also known as the Wrigley sign. And that you see on an abdominal X-ray taken in a supine view. Right. And so this is just basically, showing you the outlines of the bowel, the double walls of the bowel. Right. So, that is another option, investigative option that you can do in patients suspected to have pneumothorax who is unstable to take an erect X-ray, or when it's not practical, especially in neonates, for instance. This X-ray is of a neonate who has necrotizing enterocolitis and subsequently develop a perforation from that. So in such a case, obviously you might not be able to do a lateral decubitus or an erect X-ray. So what are some of the differential diagnoses for pneumoperitoneum? So air in the peritoneum. We've mentioned, obviously, the common one is a perforated hollow viscous. And now with the perforated hollow viscous, you're looking for all the differential diagnosis, all the possible things that can lead to perforation of a hollow viscous. In the question that we've just described, we've mentioned that is a typhoid ileal perforation. That was the most likely diagnosis based on the patient history. But aside that, you can also have peptic ulcer disease that can perforate, so leading to gastric perforations. Ischemic bowel can also perforate. Bowel obstruction that gets that can also perforate. Enterocolitis in preterm babies can also perforate. Appendicitis, diverticulitis, bowel malignancy, inflammatory bowel disease, mechanical perforation of the bowel. These are all possible differential diagnoses or possible causes that can lead to perforation of the bowel. And never forget iatrogenic causes as well. Take, for instance, a patient who's gone in for a cesarean session, and the obstetrician injects the bowel, and that leads to perforation. So these are some other that's an iatrogenic cause of bowel perforation. Now, aside the perforation of a hollow viscous, you can also have post-operative free intraperitoneal gas. And this is seen following laparotomies and laparoscopic surgeries. Laparotomy, you are splitting open the patient, you cut open the patient, and you close up. You are definitely going to trap in some free air in the peritoneum. And so about 60% of the cases of laparotomies, there's always some form of free peritoneum or gas or free or pneumoperitoneum following the surgery. And for laparoscopic surgery, about 25% of the cases of laparoscopic surgery, you have being trapped in the peritoneum. And this is because typically during laparoscopic surgeries, you have, they use this gas, typically it's carbon dioxide, that they insufflate. So they inflate, they push carbon dioxide into the abdomen to kind of create a visibility in the surgical field, by pushing. So you push the carbon dioxide in, try push various viscerals and organs away to allow you to see, to visualize the structures that you are working on in the surgery. And so at the end of the day, you now have this carbon dioxide being trapped inside the peritoneum. And the reason carbon dioxide is used because it's inert, and again, it's absorbed by the body tissue and is expelled through the lungs. So, it becomes the ideal gas to use in laparoscopic surgery. But that then means that after surgery, this gas is trapped in the abdomen until it is fully removed, reabsorbed by the body and removed through the lungs. And so those are some of the other, differential diagnoses of pneumoperitoneum. And it doesn't mean that once it's free air, it just means it equates to perforation of the bowel. It depends on the patient presentation and the patient history. Peritoneal dialysis, again, you are injecting dialysate into the abdomen, into the peritoneal cavity, and that can introduce air into the peritoneal cavity, and that can lead to pneumoperitoneum. Vaginal aspiration, so you have this retrograde aspiration of gas through the vaginum, through the fallopian tube into the peritoneum, because there's this continuum of movement of gas from the the vaginal cavity itself to the uterus, and then back through the fallopian tube into the peritoneum. That can happen, especially postpartum, when the woman is doing these postpartum exercises, when they are doing these Kegel exercises and squatting. It kind of it can trap in air through the vagina through the uterus and into the peritoneum back to the fallopian tube. So that's another way where you can have pneumoperitoneum. And sometimes even when you are doing SAG, so hysterosalpingography, when you are doing those kind of tests, you are injecting a dye in there, and it can push in gas through the fallopian tube into the peritoneum. I've put in pneumomediastinum and pneumothorax here as a last differential diagnosis, because they are least common, because gas is has a low density and they tend to rise up, and so it's very unlikely for gas in the thoracic cavity in the case of pneumothorax, or within the mediastinum in the case of pneumomediastinum, to actually descend into the peritoneum. But there are fenestrations in the diaphragm that allows for that, and so that can happen. And especially when the patient is in a supine position, where the gas is now, taking this more horizontal position, it can go through this fenestration into a peritoneum. So it's possible for that to occur. Right, so these are some of the differential diagnoses for free air in the peritoneum, otherwise also known as pneumoperitoneum. And we've just discussed a question of a patient who had a complication following a typhoid ileal perforation. Typically, enteric fever, when they are perforating, it occurs in the terminal ileum, and this is because of the presence of the Peyer's patch, the Peyer's patch, which is in the terminal part of the ileum, which plays a very vital role in the pathophysiology of enteric fever. We have a whole dedicated module where we go into acute abdomen and the various clinical features and how to manage them. Make sure to visit our site on MNEMOS, on the MNEMOS platform, and watch those videos to get more information on that. I hope this was helpful, and see you in the next session.